Hi, I'm really happy and excited to be a part of this day. I am amazed at how many common themes are in our talks, having not really spoken about what we were going to talk about. So I'll just leave that, and you can see in my slides all of the themes that we've talked about come up. I'm going to try to tell you a story about racial disparities, or what I like to call, echoing Wendy's sentiment about what are we saying when we keep talking about the word disparities. I like to call it the black-white mortality gap to really emphasize what I'm saying in endometrial cancer and my journey in trying to change the conversation around this topic. So this is my prerequisite picture of the uterus. I like to put it on my slides as a GYN oncologist. The endometrium is the lining of the uterus, so it's the lining of the womb. Endometrial cancer is actually the most common gynecologic cancer. It's 4 times more common than cervical cancer. So you don't hear about it, but it's actually our bread and butter. We treat it every day, all the time. The lifetime risk of a woman in the US is about 3%, or about 1 in 37 women over the course of a lifetime. And so to compare to breast cancer is about 1 in 8. So less common, but certainly still very present. And endometrial cancer has this reputation of being a good cancer. You know, this is what, if you happen to be in conversation with a gynecologic oncologist, they would tell you, oh, that's the one you want to get. You know, it has really good 5-year survival, over 80%, which is good in the cancer world. So even though there are about 60,000 new cases every year, there are only about 10,000 deaths. But of course, this is just one experience of endometrial cancer. And there's another one. So this is Gwen Eiffel. She died last year of endometrial cancer. I don't know the specifics of Gwen Eiffel's story, but I can tell you that she died little over a year after she was diagnosed. So somehow she didn't fall into that 80%. And she represents the other story of endometrial cancer. So I'll just briefly say that another term you'll often hear is uterine cancer. There are some uterine cancers that aren't endometrial cancers, but I will use those terms interchangeably for the purpose of this talk. And this is the incidence of endometrial cancer. And the yellow line is white women, and the red line is black women. And the purpose of this, there is an increasing incidence among black women that I will not be focusing on. It probably has to do with changing hysterectomy rates, but you can see essentially that the disease burden is similar by race in terms of white and black women. And this is mortality. So, yeah. So this is everybody, the black line. The yellow line is white women, and the red line is black women. So not just in magnitude, but this goes back to 1999, and you could make the same graph for the decade before that and the decade before that. And it's getting worse. So what is going on here? So naively, when I started looking at this, I thought, well, maybe this is just what racial disparities looks like in cancer. You know, we know that there are racial disparities in a lot of disease types, but actually this is pretty bad even among cancer. So on the right there, you see the black-white mortality rate ratio. So essentially comparing by race the mortality burden of the top 10 cancers, and you can see, or the top 10 burdens, I should say, or disparities. And uterine cancer is number 4 in the top 5. After that comes breast and colorectal, and the other ones you tend to hear about. And within endometrial cancer, within the actual different subtypes of endometrial cancer, it gets up to almost a 3-fold increased mortality among black women. So why so long? Why have you not heard about this? Why are there not campaigns? Where are the intervention programs? What is going on? And so I wanted to answer this question, and I think it's probably a good time to mention who takes care of endometrial cancer. So I'm a gynecologic oncologist. A lot of people haven't heard of us. We're a small subspecialty of OBGYN. So after medical school, you do 4 years of OBGYN residency, and then you do 3 to 4 years specifically of GYN oncology training and fellowship. We both do the medical and surgical treatment of cancers of the female reproductive tract. So we are holistic in that we do chemotherapy and surgery, but we're narrow. So we just take care of cancers of the reproductive tract. There's a little over 1,000 gynecologic oncologists in the US. Most are male, most are white. The most updated statistics I have are maybe 3% are black. I think that's probably an overestimate since I could probably name all of them. So there's, I think, maybe around 15 to 20 of us. And then if you start talking about who's doing research, you start to get in literally like less than 5. It's so good to be in this room. So to start to answer this question, and I didn't mention, I was going to mention this is going to not be that much of a quantitative talk, more of a qualitative talk, but I was interested in this question, and so I reached out to Chandra Ford, who developed the public health critical race praxis, which I learned about in graduate school, as a way to critique knowledge production in a field. And I reached out to her because I wanted to understand what has been going on with endometrial cancer disparities. I had seen some of the publications in my field and thought there might be a story there. So we reviewed all of the articles we could find on endometrial cancer disparities and found some interesting things. So in terms of what is considered the main causes, the overwhelming emphasis is on the potential for molecular and genetic factors to explain this disparity, as well as the known fact that Black women do have a higher burden of high-risk histology types, similar to breast cancer where Black women have more triple-negative disease. In endometrial cancer, Black women do have a higher proportion of high-risk histology. And that is essentially the focus of most papers, and discussions and kind of hypotheses in the discussion sections. I wanted to ask the question of how is race conceptualized in the literature? How is racism dealt with as a concept? How is discrimination thought about in this long-standing inequity? So what I found was that race is defined almost exclusively as a biological and really specifically genetic entity, and I'll show you an example of that. There was this amazing assumption over and over again that healthcare environments represent colorblind spaces. There were a few publications cited over and over again that, well, even on clinical trials, Black women didn't do well. And this is a colorblind environment, so it must be genetic and a genetic issue. There's a study out of the VA, and there was this idea that, well, in the VA system, access to care is equal. There shouldn't be racial disparities, so if Black women aren't doing well in the VA system, there must be something genetically different about them. Really no work to address repeated documented treatment inequities. So again, as Wendy was pointing out, every 10 years there'll be a sensational article that Black women are not getting surgery at equal rates to white women. There are systemic, national differences in who gets surgery, who gets chemotherapy. No intervening intervention studies, no pilot work. I'm not really speaking here about solving the problem, but even taking the first steps of understanding the problem. So almost this idea that we're rewarding the documentation of disparities over any attempt at action. And then just almost a near absence of the Black woman's voice. So no qualitative work, no interview studies. There's one paper I found that included survey results from Black women, and that was it after all this time. So I just wanted to, not in my words, but in the words of some researchers in my field, show you what I mean. And this is from Gynecologic Oncology, which is our flagship journal. The greatest limitation in studying racial ethnic disparities is the reliance on the use of race as a categorical, self-reported variable. Researchers agree that the true understanding of the etiology of such disparities relies on the decomposition of race as a category into those genetic aspects underlying its classification. 2016. This is my favorite because it's in the discussion of a negative paper, yet another negative paper in this search for a genetic reason why Black women are dying. The growing body of literature that have failed to identify gene expression differences in tumors from Blacks and whites should not temper the pursuit of biologic etiologies associated with racial disparities in endometrial cancer outcomes. This is where we are right now. So I have a different perspective. And it's, I did not come across this immediately. I mean, I was baked in this environment as well, and it took separating myself from the clinical environment and specifically learning and reading about disparities, taking graduate school classes. I'm so excited about this symposium, this whole idea of learning about how different fields conceptualize things, for me to finally notice that this is something that I was interested in studying. So I'm certainly not standing up here as a genius or something. I just read other things. So I would say my perspective would coalesce in the perspective that Jo Phelan, her fundamental cause theory, that differences in outcomes based on social position in the society arise in the context of a treatability of a given condition. Endometrial cancer is highly treatable. Most women survive, most women are diagnosed early, and we see huge racial disparities, which race is a social position in the US. And so the assumption that I moved forward with is the magnitude of this mortality gap is not solely or even primarily due to genetic factors, which is maybe a new idea. So again, echoing talks you've heard, my first project was to do a cohort simulation of what if treatment was equal. And due to time, I'm not going to spend a lot of time on the details of the mechanics, also because Wendy basically did that with her talk. But we used the population from the SEER registry, so about 35,000 women that had been diagnosed with endometrial cancer over 5 years. We specifically included this definition of high versus low risk histology in order to account for the higher burden of high risk histology among Black women. And we identified the associations among real world outcomes of race and these various treatment issues. And then we modified our models to say, well, what if surgery rates were similar by race? What if stage of diagnosis were similar by race? What if people just had equivalent treatment? And this large gap, what we found was at least 40% of the mortality gap can be attributed to stage of diagnosis and surgery. And so my hypothesis became that stage of diagnosis is a major modifiable contributor to racial disparities in endometrial cancer. The reasons being that racial differences in stage of diagnosis, they vary by healthcare setting. So this is something that came out of my review, and I pulled out these numbers and just started to note that, you know, Montefiore Medical Center, 25% difference in race by who's diagnosed in early stages versus the VA where it's 8% versus Henry Ford where it's 5%. Unlikely that these populations of Black women are genetically distinct. The other thing that I wish I had more time to go into is that the guidelines for the workup of the chief symptom of endometrial cancer, which is postmenopausal bleeding. So after a woman goes through menopause, is finished with any vaginal bleeding, she has an episode or multiple episodes of spotting or bleeding. This is the cardinal sign, and this is why we diagnose most women in early stages. The workup for this is really varied. There's a lot of steps that you can take. There's no time limitation on it. And so we know from like the quality literature that when you have that amount of variation, that's when you can start to see these disparities based on quality and access to care. And that is certainly the case with the workup of endometrial cancer. And then something I find really interesting is adherence to the guidelines might be influenced by the normalization of bleeding in Black women. And this actually is something I did not think about until I read Angela Davis, Women, Race, and Class, or Women, whichever order it goes in. And it was just, I started thinking about how do we think of Black women's bodies differently? What do we tolerate? And this is not research, this is lay conversation. I'm just asking women that I know, postmenopausal women. So Black women in my family don't go through menopause, we just keep on bleeding. You know, Black women have heavy bleeding, we have stronger periods. If it wasn't too much bleeding, I just wouldn't worry about it. And then among women's healthcare providers, so theoretically the person that if you are a Black woman and you had bleeding, you would go talk to, don't Black women bleed for longer? They go through menopause later, right? These are casual conversations, well, Black women have lots of other reasons to have bleeding. So I wonder, and I'm interested in studying whether this is an area where both from women, from patients and providers, we have a very racialized view of reproductive symptoms in Black women, and especially among bleeding, where we're kind of coalescing and creating this delay of diagnosis and this complacency with a symptom that should, you know, prompt alarm and workup. So my ongoing and future research, which I can now say is funded by the National Comprehensive Cancer Network, is to define the diagnostic care pathways in endometrial cancer. to assess the knowledge, attitudes, and beliefs about postmenopausal bleeding among Black women, and really my favorite is the attitudes and practice patterns and decision-making among women's healthcare providers. I have a lot of acknowledgments I don't have time to go through, but I would just say my goals are to change the conversation in endometrial cancer and just the awareness. So you've heard of this problem, and if you have ideas, I'd love to hear them because we need more people thinking about this. Ultimately, to narrow the mortality gap, and anybody interested in racial disparities or issues of equity in women's health, I would shamelessly point you to an op-ed that I co-wrote with some other very, very freshly minted subspecialists in OBGYN about really the disparities over the life course of Black women in this country with respect to reproductive health care.